entonces la sesión de hoy y, como sabéis, hoy tenemos la fortuna de que está con nosotros Ricardo Fontes Carvalho. Conocemos, participamos en diferentes actividades. Él ha estado aquí frecuentemente en las sesiones de Santiago sin fibrilación auricular y alguna otra vez, y realmente para todos nosotros y para mí en particular es una satisfacción que Ricardo esté aquí hoy con nosotros y pueda pasar también un tiempo esta mañana con nosotros en cardiología. Todos conocéis a Ricardo. Ricardo es el jefe de servicio de cardiología del Hospital de Gaia, que es uno de los mayores hospitales de Portugal. Además es catedrático de cardiología de la Universidad de Porto y tiene diferentes áreas de investigación. Yo diría que una de las más atractivas es de lo que hoy nos viene a hablar aquí. Él también trabaja de forma muy activa en patrones de insuficiencia cardíaca, especialmente en insuficiencia cardíaca con fracción de eyección preservada, que es un área en donde nosotros tenemos también mucho interés, y específicamente en un foco como es la actividad metabólica de la grasa epicárdica y su relación con diferentes cardiopatías, también con la fibrilación auricular. Recientemente han publicado un paper muy interesante en la Revista Española de Cardiología sobre este tema. Y hoy nos va a hablar de imagen cardíaca avanzada y un poco de radiómica en la imagen cardíaca. Cada vez más la imagen cardíaca va a un análisis más cualitativo y cuantitativo, y cada vez va más, y sobre todo el CT, que es quizás el área que tiene un desarrollo mayor en imagen cardíaca, hasta algunos aspectos de imagen, más allá de caracterización tisular, que probablemente algún aspecto nos hablará hoy aquí, incluso hasta aspectos relacionados con imagen molecular, que yo creo que es un poco el futuro, y como muchos yo también creo que el futuro, el gran futuro de la imagen estará vinculado al desarrollo del CT y a estas herramientas vinculadas al CT. Por tanto, Ricardo, muito obrigado por haber aceite hoxe tamén o convite e vamos a comenzar. Saludamos a nuestros colegas del 12 de octubre que me dicen que están ya conectados a la sesión. La sesión es en abierto, pero específicamente con el 12 de octubre de Madrid, que están todos conectados, y luego en el debate ellos podrán conectarse también de forma directa para participar de forma activa en el debate, porque como sabéis estas sesiones desde este año son conjuntas 12 de octubre y el Hospital Clínico Universitario de Santiago. Por tanto, Ricardo.
Hola a todos, buenos días. Primero que todo, es un gran placer de estar aquí hoy con ustedes, tantos amigos aquí asistiendo a esta charla. Una gran honor de estar aquí recibiendo esta simpática invitación. Es con muy gusto que vengo aquí a Santiago, mas también con los amigos de 12 de octubre en Madrid. Una saudación para ellos también. Perdona que mi español no es muy bueno, hablo un poco de portuñol, es algo como esto. Y por eso voy a continuar la charla en inglés. Pienso que todos lo comprenden muy bien. The topic that I have been assigned, as Professor Juanate said, is, I think, in my opinion, very interesting, is fascinating, especially because it helps us to look a bit to the future of cardiovascular imaging. In general, I would say that we are still in the very beginning of the development, of the clinical development of the technology. But what I will try to do in the next minutes is to give you an overview of what is happening in this field, what we are doing also in this field, what are the advantages, but also, as you will see, several of the limitations that the application of radiomics can have in cardiovascular disease. So starting what has been happening in the last years, I would say that this is something really fascinating, and not all specialties can say that they have done this for their patients. This is absolutely amazing because this is about the 200th anniversary of New England Journal of Medicine. And you can see what happened in the management of patients with cardiovascular disease. And here it is very clear what we have been doing, the advantages that we were able to give to our patients with a very significant reduction in cardiovascular mortality, which has happened due to the development of several technologies in the field of cardiovascular medicine. The second thing which is interesting to analyze in the last years is how did we manage to have such a big success in the management of cardiovascular disease. And all the analyses that we have been doing show that about half of this success is related with an improvement in the control of cardiovascular risk factors. So we have been doing a fantastic work in the management of patients with cardiovascular disease. But we should not stop here. And what is happening now in this new era and the way on how we are evolving and treating better our patients is by the incorporation of several tools, not only radiomics, but all the omics, but also big data analysis to develop what we nowadays call the precision medicine, which is adapting the best treatment, the best diagnosis to each patient. So this is something that is the future of cardiovascular practice, and what we are now moving it is into this idea that you need to individually tailor the therapy that you apply to your patient. So we will go to this in some minutes. At the same time, and we saw this fantastic evolution of cardiovascular disease management. Another thing which is happening very quickly is the development of new cardiac imaging tools. And in this field, in the last 10 years, it has been absolutely fantastic, not only the new technologies that we have to see the heart, but how we are able to incorporate this into the management of our patients. And I usually say that every time that you do a CT, an echo, an MRI, you are doing some principles of individualized or personalized medicine, of course, because nowadays imaging is very important, not only to understand what is happening to each patient, but of course also to guide the several therapeutic interventions that we have. Again, here in cardiac imaging, a new thing is happening, and it's happening very fast. So cardiac imaging is evolving very rapidly because the incorporation of artificial intelligence, all these new tools that we have for automatic analysis of imaging, immediate reporting, fast acquisition protocols, and also now radiomics is changing the way on how we will do CTs, MRIs, even echoes, because as you know, nowadays there are even softwares that where you upload the images and you have an automatic echo report of a patient. So this will change completely the way on how we manage patients and how we see the heart. So, but this is what has been happening in the last 10 years. What is interesting, and this was the topic that I've been assigned, was to discuss what is the role of radiomics in medicine. And radiomics is just one piece of the puzzle of this new idea of multimodal biomedical artificial intelligence, where by incorporating new tools, you will be able to deliver a different way to deliver healthcare to our patients. So, but what is radiomics in practice? We have here two images, one CT, one MRI, and we are used to recognize as imagers patterns where we identify if this is disease or if this is a healthy heart. But we all agree that in this kind of images, and although we do this qualitative analysis every day, we have a lot of information in these images that go further beyond what the human eye can see. So what is radiomics doing is a process of extracting the features coming from all the image, for instance, from the heart, and through several calculations I will show you, to create very big data sets with hundreds of parameters that will quantify the findings in these images. To simplify this, we are changing the way on how we assess the image. We are used to do a qualitative analysis, but with radiomics, we are able to have a quantitative imaging. So we are transforming a big amount of information coming from the images of CT and MRI to numbers, to quantitative, to perform then a quantitative analysis of the data. So what is happening is that radiomics is, again, a piece of the puzzle of this idea of individualized medicine, and has emerged in the last years as one of the most promising advances in medical imaging. Everything started in oncology, so radiomics started to be used especially in oncology, and now they are incorporating, this was the current model, but some studies are incorporating radiomics analysis in the assessment of the patients. So what is up to date nowadays in the field of oncology, and it's coming, is that you include also the information, not only from traditional imaging, the genomics, the histology, also the information from radiomics, to have an improved diagnosis, to have a differentiation of the type of tumor that the patient has, to have a prognosis prediction, but also to assess the efficacy of the treatment. So this is moving, and it started especially in oncology. What is the kind of information that we get from the images, and especially from cardiac images? So when we do this kind of analysis, we extract the information in features. And we have several, sometimes hundreds of features of different levels. You have what we call the first order statistics, the first order features, which are based on the histogram method, but also we extract parameters which are based on shaped base parameters, but also we extract this information which come from gray level co-occurrence matrix. So we extract from the images and the pattern of image, but also the grayscale of the image from CT or MRI to extract this is from one of our studies. You extract a large number of data, of numerical information, which is the transformation of the image in numbers, to analyze what is happening to the patient. So what we are doing, and I will show you several examples of how this can be applied. We published very recently a study which was something which is interesting, which is correlate not only the radiomics coming from CT with the proteomic data, because we had some biopsies. So we did the CT of the patient. This was a study related. I will explain in a short time what we did in this study. We extract, as you can see here, several types of features, the first order features, then the 2D and 3D shape related with volume, area, and compactness. And with this, we have these numerical numbers, and then with this we will do the correlation not only with outcomes, but it is possible to do here. We also try to understand which features relate to the proteomic profile of the epicardial fat, which was the aim of this study. But for you to understand what we do when we need to do a radiomics analysis, I think this is one of the essential figures that I will show. So we need to have the acquisition of the image, CT or MRI. Then this is a very important step, I will show you in a minute, because we need to do a careful segmentation of what we want to see. For instance, if we want to see the heart, we have to do a very careful segmentation of the whole heart, or if you want to see epicardial fat, it is a different thing. If you want to see abdominal fat, you need to do the segmentation. From this, I will show you, you need to generate not always the three-dimensional volume, and then you have a special software, which is usually PyRadiomics, where we will extract all this information, you quantify this in numbers, and then you need a good statistician to build the models and to have the correlation with the events, as I will show you in a moment. As I showed you, you can do this by CT. The examples that I showed until now was with CT, but also there is several examples where you can also do this with the image coming from the CMR. Moving forward, what we will try to understand, until now we try to understand more or less, I need to be quick, the technology, what is the technology behind. What we will try to see is what is published already about the role of radiomics in cardiovascular disease management. And I had a very difficult topic, which was how radiomics can help the cardiology decision-making process, okay, which is even more interesting because we need to look even further because, as I said in the beginning, we are still in the beginning of the development of this kind of technologies. But what we will see what has been published already and where we are going, and I will also share some of the projects that we are developing to try to go in this direction, to change the way on how we treat patients, incorporating the information coming from radiomics. There are several interesting articles which are assessing the clinical applications of radiomics in cardiovascular disease. The first interesting paper is this one, which was published in European Heart Journal Cardiovascular Imaging, where they try to evaluate if radiomics can improve the prediction of or the identification of the vulnerable plaque. So here they had 44 plaques. They had the information from IVUS, from OCT, and from PET, and they incorporated the image from the CT of the coronary artery CT to see if the radiomics, the analysis of the radiomics of the coronary CTA could help to better identify the vulnerable plaques on OCT and on IVUS. And as you can see here, with building this analysis and building this model, the incorporation of coronary radiomics identified the invasive and radionuclide imaging markers of plaque vulnerability with a good to excellent diagnostic accuracy, as you can see here in these rock curves. So the conclusion here is that it can be useful to identify patients who have vulnerable plaques, the incorporation of radiomics in the assessment of the CT, of patients with CT. Another interesting article which goes into the same direction, so here we are discussing papers related with coronary artery disease, is this one which incorporates the analysis of CT, but here they focus on the perivascular fat, okay? As you know, perivascular fat is more and more associated with the development of plaques and especially unstable plaques. As you can see, they perform this kind of analysis. Here is an example of the features. You can see very well the pericoronary radiomic features and the pericoronary, and here the individual cases. So this is the kind of information that you had. And what is interesting in this study, and this is why this is fascinating, is that they started with this analysis of CT from radiomic features, but then they move forward and they use also the data from CT from the very large Scott Hart trial with more than 5,000 patients and 5,000 images. So what they were able to demonstrate, and I think this is interesting, is that when you look to the characteristics of radiomics of this perivascular fat, you are able to identify patients who have a more vulnerable plaque. But what is more interesting is that when you apply this to the general population of the Scott Hart, this information coming from radiomics helped to improve the discrimination of the occurrence of MACE events. So here a demonstration on how the incorporation of radiomic analysis here of perivascular fat can help to predict, not only understand the disease, because it is interesting to understand that the patterns, the features which were associated with more inflammation had a better correlation with events, but also that by incorporating radiomic features, you can have a more discriminative power to predict major adverse cardiovascular events. So a good example in the coronary artery disease world. But I think, in my opinion, that there are two major areas where radiomics would be useful and will be more likely to be incorporated in our clinical practice. Here is a very also a fantastic example, and I think here shows a bit of the future. So these are patients, almost 2,000 patients from, this is also very well known, from the Dallas heart study, and the patients came to perform a calcium score, okay, just for general assessment of the calcium score. So what they did in this study is that they tried to incorporate and to understand if the analysis of the heart, not the calcium score, but the characteristics of the heart, could help to identify patients that coming for coronary CT for calcium score, if they had hypertrophy, and if this hypertrophy could be for example, a patient with hypertrophic cardiomyopathy. So this is interesting because they extract the features, again, a large amount of features, and what they show in this study is that although we don't look at this information when you do a normal calcium score, they were able to identify some patients who not only had hypertrophy, but who had patterns which are associated with the disease. So I think this is very interesting because I think this shows us a bit of the future, which is we will do an exam for some kind of purpose, and this kind of technologies, also incorporating artificial intelligence, will help us to screen other diseases that we could not be able to diagnose because we were doing the exam for other purpose, and this is very interesting to see how the technology is evolving. The third area that I think radiomics can have a good future is in the study of the myocardium and to understand better some cardiomyopathies. And I will show you two examples. Here is a study which has been published with images from CMR from T1 mapping. And what they show here is, again, the features. They extract the features. You can see this very well here. And they show that in a small sample, 200 patients, they were able to differentiate with the radiomics data if this was a patient with hypertensive heart disease or if this was a patient with hypertrophic cardiomyopathy. So a way to improve the differential diagnosis between the two diseases. But another interesting study, and this will be the last that I will show you, because again, this is very interesting because it can also help us to show the future. This paper is not published yet, is on press, but this is very interesting because this is what they did was, see the amount of data. They analyzed data from more than 1,000 patients with CMR. They incorporate the analysis of the late gadolinium enhancement. And what they did was to incorporate radiomics data, several features that they analyzed. They incorporate this with the score for sudden cardiac death stratification. So they put this separated, radiomics versus the score, and then radiomics plus the score. Here is the features that they extract, okay? And then what they show is that if you incorporate the two, the clinical data, also together with the data of the radiomics features, you have a significant improvement in your prognosis, in the prediction of events of sudden cardiac death. Because one thing that is interesting is that radiomics is a good tool to assess the structure of the muscle. So this is several examples on how we are doing. The question is, but is radiomics the holy grail to understand all the cardiovascular disease? I would say not yet, of course, because we are in the very beginning of the development of the technology. There are still several limitations in the technology, especially the reproducibility of the technology that I will show you with some of our data. It all starts with the acquisition of the image and also the kind of pre-processing steps. it is not recommended nowadays to use features. As you know, you can extract hundreds of thousands of features, which are highly affected by the acquisition and reconstruction parameters for clinical applications. This makes sense, but there are nowadays ways to standardize better, not only the acquisition protocol, but the kind of pre-processing that you do in this analysis, because there are groups of people who are actively working on this standardization on how you acquire the image. The second challenge, and this is why this is a critical step, this is an example from our department where we do this segmentation of the heart. What is interesting is that you must be very careful when you do the segmentation. You understand that depending on the segmentation, the features which are based on shape, which are based on structure, can be affected depending on the segmentation that you do. So one important thing, here is another example from segmentation for epicardial adipose tissue assessment. This is the kind of tests that we need to do nowadays. As you know, it is possible to do segmentations manually. It is nowadays, there are several softwares who do the segmentation automatically. There are some which are from Siemens. For instance, this was developed by our engineers, this UNET. And what is interesting is that usually when you have human operators, you have a very good reproducibility, but when you insert the automatic tools, you have, in different exams, you have more similarity, but it's not always as humans. But here is the preliminary results of the impact of segmentation on radiomic features, and we are moving to this kind of automatic analysis because the variability is still good. It improves a lot the amount of time. Sometimes you take 15 to 20 minutes to do each segmentation, and it reduces the inter-individual variability in the extraction of features. Then, after segmentation, as I said, we have engineers working with us who do this job, which is extracting with this software, which is PyRadiomics. They extract the thousands of features, and then you need to do another crucial step, which is selecting which features have a more discriminative power to the kind of study that you want to do, because if you use a large number of features, you can have overfitting in your models, and that is why you need to select the features that you want to analyze. And then, of course, you need to build the statistical model. So this was just to show you that there are some important methodological steps if you want to do this correctly, and if you want to have a good reproducibility of what you are doing and to have a clinical impact for the studies that you will do. In the last part, I will show you some ideas of things that we are doing now and things that we have already done to have radiomics to improve our clinical practice. So this is the first example I will show you, so I will explain very briefly. So here in this study, we had a lot of information from patients with aortic stenosis, where we had samples of epicardial fat of these patients. So all patients did a CT. This is a large cohort of patients with severe aortic stenosis, and because these patients were sent to the cardiac surgery, we had also the samples from the epicardial fat. So in this study, we analyzed the features from radiomics, and then we tried to put the two things together to understand which features could correlate with the phenotype, more inflammation or reduced inflammation, more activation of platelets, so that we can have also an understanding of the kind of features, how they correlate with the data coming from proteomics, as you can see. And what we were able to show is not only this correlation, that some features correlate to specific patterns in terms of proteomics, but if you incorporate the radiomics analysis, you are better to predict the risk of atrial fibrillation after cardiac surgery replacement. So it can have a clinical impact. Second study that we are doing, we already have this huge amount of information where we are able to extract the features, the radiomic features, not only of epicardial, but also abdominal fat. We are still analyzing this data, is to try to understand, as you know, the distribution of fat is able to predict the risk of cardiovascular events. We published this 3 years ago in a very large sample of patients coming for cardiac CT. And here what we did was to analyze not only epicardial fat, but also abdominal and visceral fat, incorporate radiomics to predict the risk of, to predict the presence of coronary artery disease. I'm not going to enter in all the details, but the data are interesting that we are able to understand based on these features of fat to predict the presence of coronary artery disease. The third thing where we are moving, Professor Juanate talked about this article. We published very recently in your in Revista Espanhola de Cardiologia that this is a very large sample of 350 patients undergoing atrial fibrillation ablation, and we wanted to understand if epicardial fat volume, quantity, is related with the risk of recurrence of atrial fibrillation. Actually, this is a negative study because although we did a lot of analysis in this, we were not able to show that the quantity of fat is related with recurrence of atrial fibrillation after the procedure. But what we are now finalizing is to assess if we look not to the quantity, but if you look to the features of epicardial fat, because as I showed you some time ago, some features are correlated with inflammation, are correlated with several activation processes, to evaluate if this signature of radiomics is able to predict better the recurrence of atrial fibrillation. So we already have the data extracted, we already have the features, and we are in the final process just of modeling and building the statistical model, and I think this will be promising. Two last projects, because I think they show a bit of the future. I think this one will be, for sure, it will have an impact. In this study, we had, as you know, in our department, we do nowadays all pericardial synthesis, we do it's guided by CT. So we have a lot of information coming from the fluid, from the imaging from the CT, and all the clinical data. So what we have already done was, again, segmentation of all these images. This is already done. We already have the features to assess if the pattern of pericardial effusion by radiomics can help to predict what is the cause, the etiology of the pericardial effusion, if it is an exudate or a transudate. And we don't have yet the results. I tried to have the results to this meeting, but I was not able. But for sure, this will give information because it makes sense that looking to the pattern of the pericardial effusion that you will be able to at least differentiate if it has blood or not, does not has blood or not, if it is an exudate or a transudate. So I think we will have these results in less than 1 month. And the last project, which is we are trying to build a cooperation with you and with Santiago, is what we do nowadays is an interesting project. What we do nowadays is to assess if the patient has coronary artery disease. Usually we start doing the non-contrast CT, then we put contrast, and then we will have the classification of coronary artery disease. So the idea here, and this is the SAFE CT project, and we are building a consortium to analyze this, is to do, based on this non-contrast CT, incorporating here radiomics analysis to at least identify the patients who are very likely to not have the disease so that you don't need to proceed with the injection of the contrast and to increase the radiation. So the data from the preliminary analysis is interesting. So this is the idea: a large population, extract the features, build the model, and then try to applicate this like a plugin, and you put a plugin and the software could give you the information, okay, you should move to the injection of the constructs, or you probably will not need to move to this further step. So this is a project which we are building, and we tried to apply it last year in this idea, which joins together clinical people. These are our engineers from INESCTEC, the department, your department, but also we have a cooperation with the University of Oxford. Final message: you only are able to do this with a very strong teamwork. As I said, clinical people, we have a lot of students working with us to do all these segmentations, because we are in this process of building the segmentations. We need, as I said, clinical people, statisticians, we need the engineers, we need international cooperation, because we are in the early phase, and because we are in the early phase, this is not easy to standardize. So what are the main conclusions and take-home messages? The main conclusions and take-home messages I finalize with one of my favorite paintings, okay? This is, I usually call this like the Mona Lisa of medical practice, okay? Because this is a fantastic painting, really fantastic, because it shows the practice of medicine in a hospital in France at the end of the 19th century. And as you can see here, the practice, something which is interesting is how they did, of course, lung auscultation, quite particularly, but also how practice evolved throughout the years. And we had at that time the eminence-based practice, that we are now moving to the evidence-based medicine, where you need to build up the data, to do the studies, and then to demonstrate your ideas. So this is, we published this quite recently, and this is a very nice painting because of several things that I don't have time to go into all the details, but actually show us the importance not only of medical practice, but also medical teaching. So to conclude, I would say that radiomics is moving. Radiomics is coming to the cardiovascular medicine. Until we have more data, the early data is interesting, but we should keep calm and remain what I usually call cautiously optimistic. Thank you very much for your attention.
Ricardo, for this fantastic talk on the future. Realmente es hacia donde nos estamos moviendo este tema de la medicina personalizada, que no solo viene de la genética, sino que viene de múltiples aspectos, desde aspectos clínicos elementales, que es la mejor forma de personalizar el diagnóstico y a veces el tratamiento, la personalización con elementos complementarios básicos, y ya luego pues la imagen cardíaca, que es un elemento central en el proceso diagnóstico y terapéutico también de nuestros pacientes, como la imagen cardíaca nos puede ayudar en esa personalización. Yo, antes de que se esté preparando un poco para que los colegas del 12 de octubre inicien también parte del debate, una pregunta. Bueno, sabes que cada vez más estamos intentando personalizar a quién revascularizar y qué lesiones revascularizar. Por ejemplo, en el síndrome coronario agudo, pues está claro que la lesión culpable, y ahora cada vez más hacia la revascularización completa. Y bueno, ¿tú crees que más allá de otras técnicas de imagen y funcionales, como pueda ser el FFR u otras técnicas funcionales, el análisis cualitativo de la imagen de la placa estaría ya listo para lo que veía decir, para la toma de decisiones, o falta? ¿Y tú crees que ese es un área que realmente podría ayudar, porque llevamos mucho tiempo hablando de esto, que esa caracterización tisular o esa radiómica de esas placas pudieran definir qué placas conviene revascularizar e incluso qué placas no conviene revascularizar en ese aspecto a mí esa me parece un área central, porque estamos siempre moviéndose de revascularización de la lesión culpable, luego de la lesión culpable, revascularización completa, a veces vamos para adelante, otras veces para atrás. ¿Tú crees que este es el área quizás más prometedora de personalizar qué placas se podrían revascularizar?
I will answer in English because it's better for me. My answer is yes and no, okay? Why yes and why no? Yes, because the concept is very interesting to better assess which plaques are more vulnerable or more likely to cause an event, and we should go to OCT, IVUS, radiomics to try to understand which are the vulnerable plaques and then which are more likely to cause an event. However, I would say that history has shown us in the last 10 years that the concept of vulnerable plaque has been very difficult to apply to clinical practice. What I mean with this is we invested hundreds of thousands of millions of dollars in the concept of vulnerable plaque. We do all kind of analysis, virtual histology of the plaque, and we were not able to, not only we are able to identify which plaques are more likely, but we were not able to have the fundamental step, which is these plaques you should dilate or do something, and because this will reduce events. So I think this concept has been very difficult to apply because we know also that a lot of vulnerable plaques can even rupture and do not cause an event, which is another interesting theory, which is why some plaques rupture and cause an event and why do some rupture and heal naturally. So I think this goes into that concept of what is more important, the vulnerable plaque or the vulnerable patient, okay? Yeah. So this is very interesting to discuss, but I think that radiomics is not going in this direction. It's difficult to go in this direction.
Al final tú tienes que tomar una decisión, obviamente, en base a las características del paciente, qué paciente es más vulnerable, pero de alguna forma tú también tienes que obtener algún tipo de información de la placa que te oriente. En ese paciente vulnerable, estas son las placas que merecería la pena dilatar, y estas son las que si tú dilatas podrías tener incluso problemas en la dilatación de esas placas, ¿no? Ahora Juan Delgado creo que ya está desde el 12 de octubre y yo creo que podemos iniciar el debate con ellos.
Buenos días a todos.
Buenos días.
Buenos días.
Se repite.
¿Tenéis alguna pregunta para nosotros?
Claro. Buenos días, queridos compañeros del Hospital de Santiago, profesor Fonte Carvalho, thank you very much for this talk about cardiology, how cardiology can help in decision-making process. And my question is about heart failure and reserve ejection fraction. Do you think that radiomics can help us to better phenotype this group of patients with heart failure?
Thank you very much for this, I would say, interesting but also provocative question, because what is interesting is just to go to 2 or 3 things, which is more and more we can see all of you now. Hi, everybody. We can see you very well. I think that, again, the answer is yes and no. If you are asking me if the incorporation of the radiomics of the myocardial tissue can help us to differentiate some of the causes of heart failure with preserved ejection fraction, such as amyloidosis or other infiltrative diseases, I would say yes. Radiomics can help in this type of subphenotyping heart failure with preserved ejection fraction. But our current understanding of heart failure with preserved ejection fraction is as a clinical syndrome, which is complex, which involves several systems, which involves several organs, and it is difficult to apply radiomics of a certain area, for instance, of the heart, to understand a disease which is more multi-systemic. So I would say that in theory, it can help us to identify some kind of infiltrative diseases which are a pattern, a subphenotype of heart failure with preserved ejection fraction, but I think it will be difficult to have all the answers related with heart failure with preserved ejection fraction.
Hola, buenos días. Héctor, no sé si tenéis alguna pregunta más para nosotros.
To echo and coronary angiography images? And second, whether you have used this technology to compare changes over time in the patterns.
Okay.
To predict predictive value.
Two very interesting questions. In theory, you can apply radiomics to all kind of images. You can apply in theory to echo, you can apply to CT, MRI, even to scintigraphy. In echo, the development stopped a bit. Why? Because you had too much variability, and that is the main reason in echo we are not having a lot of studies, because it has a lot of variability, not only between patients, but even between analyses. So this is more or less stopped. In terms of CT, most of the data is we have from CT, because in theory it's the best technology to have the assessment of radiomics. Remember the limitations that I showed on how we do the segmentation, the extraction of features, and CT is in theory the best imaging technology to start. We are in the beginning of the application of radiomics. There are also some information. I showed you two studies with the use of CMR. Okay, so these are the two imaging technologies where we have these more advanced, which are CT and CMR. In my department, we are doing this with CT, although at different organs. I showed you examples of radiomics of epicardial fat, abdominal fat, of the heart, of the muscle, but CT. Regarding the other question, which is very interesting, which is if radiomics features, if a radiomic profile will change over time, I will say yes, but we don't have the data yet, okay? So this is interesting to also analyze how time will change the pattern of radiomic features, for instance, from CT and from serial CT. In cardiology, we don't have data. There are data coming especially from oncology, okay? Because in oncology, they are already using radiomics for serial exams and to understand how the tumor evolves, how the tumor progresses, and they already have some data regarding tumors. But as far as I know, in cardiology, there are no published data regarding this.
Muy bien. ¿Alguna pregunta aquí en Santiago, en la sala? Sonia.
Seleccionas realmente y a lo mejor tenemos un tejido que podría...
The question is, for people in Madrid, is about the Hounsfield units that you use to define la grasa and the pericardial fat that we use. Well, this is the problem that we have with standardization. It is written in the literature that you need to use this kind of limits. And if you introduce, beyond all the other problems that we already have in standardization, if you include other way or other kind of parameters, I think you will have more confusion than clarity if you introduce this kind of assessment. So we still use the old and standard Hounsfield units to assess fat, both pericardial and other locations of fat. Yeah, but I agree with you.
Ricardo, una pregunta. Todos sabemos que el TAC tiene una proyección impresionante en la imagen cardiovascular. ¿Tú crees que estas nuevas técnicas suponen un paso adelante en el TAC y uno atrás en la resonancia?
I think the two technologies will have for sure a future and they will be complementary. That being said, and I'm a great fan of resonancia, I think that things are moving faster in CT, okay? Even with the clinical application, not only radiomics, but also in the clinical application, things are moving fast in the CT. And for instance, if you are able, and we are doing some studies, these are very preliminary studies, where CT, with this kind of new technologies, is even able to better differentiate the pattern of the myocardium, you are entering in one of the major strengths of resonancia. So it is promising and it is interesting to see if this better way to see the myocardial tissue with CT will be able to come closer to the way on how we can see the muscle with CMR. So this is interesting. Yeah, I agree.
¿Alguna pregunta más? Bueno, pues yo creo que podemos dejar la sesión por hoy. Muchas gracias a los compañeros del 12 de octubre por su conexión y sus preguntas, y gracias a todos vosotros. Nos vemos en la próxima sesión y muchas gracias sobre todo a Ricardo por su excelente presentación y por resolver nuestras dudas.
Gracias a todos. Gracias.
Muchas gracias.
Gracias.